ISB MSN. I want to thank Dr. Jaspal Singh Tehalia. And today, one more important Karnataka State Branch End Tuberculosis Subcommittee, Dr. Sanat Kumar sir, is also the part of this program. And I warmly welcome Dr. Anil S., Joint Director and State TB Officer. Let us hear from him. Welcome each and everyone for this tuberculosis day Zoom webinar. As you all aware, World Tuberculosis Day is celebrated on 24th. Still, India is having highest number of tuberculosis, and multi-drug resistance is also one of the biggest challenges what we are facing. And let us hear from our speaker, Dr. Anil S. I warmly welcome our President, Dr. Veerbhadraya sir, Dr. Madhusudan Karinur sir, Dr. Chinivalar sir, and Dr. Vijay Kumar, everyone. And I once again warmly welcome each and everyone who has given this time for this webinar. And I congratulate MSN for conducting such impactful webinar. Let us start this program with IMA prayer. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಅಂಶಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. ಧ್ವಜವಂದನೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜಕ್ಕೆ ವಂದನೆ ಸಲ್ಲಿಸಲು ಇಲ್ಲಿ ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವವೇ ನಮ್ಮ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ, ಮತ್ತು ಅದರ ಪಥವೇ ನಮ್ಮ ಪಥವು. ಈ ರಾಷ್ಟ್ರೀಯ ಸಂಸ್ಥೆಯ ಮಾನ್ಯತೆ ಪಡೆದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ಅದಕ್ಕೆ ನಮ್ಮ ನಿಷ್ಠೆಯನ್ನು ತೋರಿಸುವ ಪ್ರತಿಜ್ಞೆ ಮಾಡುತ್ತಿದ್ದೇವೆ. ದೇಶ ಸಮೂಹಗಳ ನಡುವೆ ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜವು ಉನ್ನತ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ ಸಲುವಾಗಿ ನಮ್ಮ ಅಧಿಕಾರದಲ್ಲಿರುವ ಎಲ್ಲವನ್ನೂ ಅದಕ್ಕೆ ಸಮರ್ಪಿಸುವ ಪ್ರಮಾಣ ಮಾಡುತ್ತಿದ್ದೇವೆ. ಜೈ ಹಿಂದ್. IMA ಚಿರಾಯವಾಗಿರಲಿ. ವಂದನೆಗಳು. ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ಉದ್ದೇಶಿಸಿ ಡಾಕ್ಟರ್ ಇವತ್ತಿನ ಈ ಕಾರ್ಯಕ್ರಮದ ಮಾಡರೇಟರ್ ಆಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಸನತ್ ಕುಮಾರ್ ಅವರು ಈ ಕಾರ್ಯಕ್ರಮ ಉದ್ದೇಶಿಸಿ ಮಾತನಾಡಬೇಕು. ಮತ್ತೆ ನಮ್ಮ ಪ್ರೆಸಿಡೆಂಟ್ ಕೂಡ ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ಉದ್ದೇಶಿಸಿ 2 ನಿಮಿಷ ಮಾತಾಡಬೇಕಾಗಿ ನಾನು ವಿನಂತಿ ಮಾಡ್ಕೊಳ್ತಾ ಇದ್ದೇನೆ.
ಸರ್, ಎಲ್ಲರಿಗೂ ಒಂದು ಸಾರಿ ಫಾರ್ ಇಂಟರಪ್ಷನ್. ಸೂರ್ಯರಾಜ್ ಸರ್, ವೀರಭದ್ರಯ್ಯ ಸರ್.
ಎಸ್ ಸರ್.
ಡಾಕ್ಟರ್ ಅನಿಲ್ ಕುಮಾರ್ ಅವ್ರ ಮನೇಲಿ ಯಾರೋ ಸಂಬಡಿ ಇಸ್ ವೆರಿ ಸೀರಿಯಸ್ ಅಂತೆ.
ಓಕೆ ಸರ್.
ಸೊ ಜಸ್ಟ್ ಒಂದು ಹಾಫ್ ಅನ್ ಅವರ್ 45 ಮಿನಿಟ್ಸ್ ಕೆಳಗೆ ಕಾಲ್ ಮಾಡಿದ್ರಿ ಸರ್. ಸಾರಿ, ಐ ಕುಡ್ ನಾಟ್ ಇನ್ಫಾರ್ಮ್ ಯು ಆಲ್ ಬಿಕಾಸ್ ಐ ವಾಸ್ ಹೆಲ್ಡ್ ಅಪ್ ಇನ್ OT.
ಓಕೆ ಸರ್. ಜಸ್ಟ್
ಹೊರಗೆ ಬಂದು ಇವೆಲ್ಲ. ಐ ಆಮ್ ವೆರಿ ಗ್ರೇಟ್ಫುಲ್ ಟು ಸನತ್ ಕುಮಾರ್. ಹಿ ಹಸ್ ಟೇಕನ್ ದ ಮ್ಯಾಂಟಲ್ ಫ್ರಮ್ ಹಿಮ್.
ಅವರು ಇನ್ನೊಂದು 15 ಮಿನಿಟ್ಸ್ ಅಲ್ಲಿ ವಿಲ್ ಜಾಯಿನ್ ಅಂತೆ.
ಹೌದಾ?
ನಾನು ಅಲ್ಲಿವರೆಗೂ ಮಾಡ್ತಾ ಇರೋ ಆಫ್ಟರ್, ಬಿಕಾಸ್ ಈಸ್ ಇನ್ ಹಾಸ್ಪಿಟಲ್.
ಹೌದು.
ವಿಲ್ ಕಮ್ ಬ್ಯಾಕ್ ಹೋಮ್ ಅಂಡ್ ವಿಲ್ ಜಾಯಿನ್ ಅಂತ ಹೇಳಿದ್ರು.
ಜಸ್ಪಾಲ್.
ಎಸ್ ಸರ್.
ಸೂರ್ಯ ಸರ್,
ಅವ್ರ
ನಾವು MSN ಹುಡುಗನ್ ಸ್ವಲ್ಪ ಇನ್ವಾಲ್ವ್ ಮಾಡ್ಕೊಂಡಿದ್ದೀವಿ ಇದಕ್ಕೆ. ಸೊ ಜಸ್ಪಾಲ್, ಗೋ ಅಹೆಡ್.
So I request our Srinidhi and their team to start off the program. Initially, we can start with presidential address. Then we can start with the protocol which has been told to Srinidhi. And I think by this time we will also get Anil Kumar online. We'll start the program in the way Anil would be joining shortly. So Srinidhi, can you request the members to continue the protocol which has been defined in the morning? Srinidhi, are you there?
Yes sir. Thank you sir. Sir, IMA MSN state team member is there, sir. Shreya, she is a public relation officer. She is the hosting the event. She will take over from here onwards. Thank you, sir.
Please. Thank you.
A very
this
good
is a
evening.
MSN event.
Yes, sir. Yes, sir. You can continue, sir.
This is a MSN event, so we request all our senior members that we want our MSN young leadership to take over the whole protocol and continue with the agenda as per we have discussed with them, sir. So Shreya will take over, sir, now. Thank you, sir.
Yes, sir. A very good evening to one and all present. I am Shreya Sridharan, PRO, IIM MSN Karnataka, and it is my privilege to serve as the host for today's session on MDR TV. I would like to thank Suriraju sir for his warm welcome and for starting the session on a positive note with the IMA prayer and flag salutation. Thank you so much, sir. Moving on, may I now invite Dr. Jaspal Singh Telia sir, Chairman, IMA MSN Karnataka, to enlighten us on the role of students in TB eradication. Over to you, sir.
Thank you, Shreya. So I'll not take much time. As we now rely on most of our medical students network for their role in the community, where they can give a very big impact in helping us to end TB and what role they can play, I would just want to highlight in a few words. Now, as they are all there in the OPDs and they are all knowing all the signs and symptoms and what are the reasons how they can suspect our people in the mass areas where TB can be suspected with some symptoms which are pulmonary, which are extra pulmonary. Hence, I would like them that whenever they are in the OPD, they keep their suspicion level very high and they can start first by evaluation. Suspicion, then evaluation, then getting them diagnosed, and then finding familial chain and ruling out their leg spread. This is how. So first start with suspicion. Suspicion in case you find some patients who have got some kind of symptoms like they have got cough more than 2 weeks, fever, night sweats, hemoptysis, chest pain, shortness of breath, unexplained weight loss, evening rise of fever that was supposed to be added, loss of appetite, fatigue, swelling in the neck with other extra pulmonary symptoms are there, then give a higher suspicion in your day-to-day practice in your OPD and see to it that you are isolating such people, taking a good history and trying to get them investigated by either whatever type of investigations you have around your setups. If possible, there are NAAT kind of investigations, NAT, what we call as get them investigated. Once you get them confirmed, then get their family members also screened. And if you find that these people are really having some kind of a positive, positive diagnostic reports, then start them with treatment line, help them, get them medicines, and see to it that they get properly channelized and explained to them, counseled to them. This is what is my message for all our medical students. This should be spread and they can make a big impact in helping all our patients in the community whom they are at the reach first in their OPDs, wherever they are serving as interns or before that they are going there as students, wherever they are examining cases when they are given to present, they find such cases, talk to them, counsel them. So you can make a big impact, you can make a big contribution also here as students. You can help, you can even talk to your seniors that, sir, we are suspecting tuberculosis, like some suspicion is there in this case. Should we investigate further, screen their family members, get them investigated, and if it is confirmed, then get their family members screened up and then get a treatment done. This is how we can help all our people in the community by finally contributing to NTB program of our national IMA and the state IMA. This is what is my message to all the MSN students. So please be very alert and visualize yourself that you are the most important member in the medical student network who primarily can help in identifying, diagnosing, and getting such patients notified to your seniors and bringing them under treatment protocol. Thank you very much. This was my message to my MSN students network people. Thank you, sir.
Thank you so much, sir, for your brief yet insightful remarks. Now I humbly request Dr. Veerabhadraya, sir, President, IMA KSB, to address the attendees.
Good evening, everyone. I immensely thank MSN because you are actively involving in all webinars. Yesterday also we had one on behalf of Kidney Day. So it was also nice, and I could not complete that session because I had another meeting. But today is an important issue, burning issue in India. It's a tuberculosis. Our Prime Minister's dream is to eradicate tuberculosis by 2030. So to fulfill that dream, we all should work together. We should give hand with the government and the tuberculosis prevention officers, DTOs maybe. So we have to refer all the positive cases to district 2B officers so that they will give treatment, and there should not be any resistance. If we don't treat them properly, they will definitely develop multi-drug resistance, and we are seeing many cases of drug resistance, and the patients are resistant to take the drugs because they go for malnourishment. And even if you give nutrition also, some of the patients, because the number of tablets are more, so they are reluctant to take those tablets. So before they go for multi-drug resistance, we should detect early and start treatment early. Early detection, early treatment will prevent drug resistance. So all young doctors should keep in your mind that you should refer all the cases to the TB centers in your respective districts or taluka, so that they will start immediately and they will look after the patient. And the patient need not to spend money on tablets, and the tablets available in the market nowadays may not be sufficient. Some physicians will prescribe some drugs, and the patient, if he gets symptom free, he will stop taking all those drugs because they are expensive. So in turn, he will develop drug resistance. Again and again, he will get cough, and he will be a source of spreading infection. So I request all of you to listen to this. Our Anil is king of TB. Actually, strictly speaking, he is authority in TB. He'll speak whatever you ask in tuberculosis, he knows. So he is such a senior officer, and he has worked a lot for tuberculosis. And even Sanat Kumar also, he is the person instrumental in starting this nutrition for TB patients. He started this experiment in Tumkur district when he was district TB officer in Tumkuru, which was well appreciated by then Principal Secretary Health. And it was through donation from the like-minded friends of him, some from America, some from Tumkuru, some from Bangalore. All of them contributed a lot in supplying nutrition to the TB patients, so that in looking into this project, the government formed a committee to study the outcome of this project, and they have introduced nutrition. To give nutrition, they're paying patient every month 500 rupees so that he can buy nutritive food, and he can consume tablets as well. So this is how the TB they are working, and you should also support them in eradicating tuberculosis by 2030. So thank you all for giving me this opportunity, and wish the webinar all the best. Thank you so much.
Thank you, sir. Thank you very much.
Thank you, sir, for your valuable address. Yes, sir. Due to an unforeseen family emergency, Dr. Anil sir is unable to join us today. We are truly grateful for Dr. Gurram Krishnamurthy Sanat Kumar sir for stepping in and joining us as our speaker for today's session. I now request Srinidhi, co-convener, IMA-MSN Karnataka, to introduce our speaker.
Thank you, Shreya, for this opportunity to introduce today's speakers to the session. It is my privilege to introduce our speaker, Dr. Gulram Krishnamurthy Sanat Kumar sir. He is a public health expert currently serving as the district tuberculosis and HIV or AIDS control officer in Tumkur district, Karnataka. Dr. Kumar sir completed his MBBS from Sri Siddhartha Medical College and later pursued a master's in public health from the Institute of Tropical Medicine, Belgium. With more than 2 decades of experience in government health services, he has made significant contributions to strengthening TB control programs, improving treatment success rates, and reducing HIV prevalence at the district level. He has also been actively involved in operational research and has authored several research publications in international and national journals on tuberculosis control and public health programs. His work has been recognized with the prestigious awards, including Sarvotama Seva Prasasti for outstanding public service. Today, we are honored to have him to share his valuable insights with us. Please join me in welcoming Dr. Sanat Kumar sir to this session.
Thank you, sir. I would thank Dr. Jaspal sir, chairman, and President IMA, Dr. Veerbhadra, for giving me an opportunity. Sorry to tell her, Dr. Anil was in some issue, so he will join in the 15 minutes. Maybe he can answer the questions. You can raise it. So I would like to start with the this World TB Day theme of 2026. Yes, we can end the TB led by countries powered by the people. So we can end. So usually we would have ended TB in 2025 due to the COVID and other diseases emerging. The TB could not be controlled. So the elimination has gone 5 years ahead now. So maybe we can achieve in 5 years. So during this, this is a man-made drug-resistant TB because we always people go for the regimens, different regimens. So we don't stick on to the treatment regimens. So that's why the people are going for drug-resistant TB. So we have come across many protocols and many updates in the TB program and the treatment also. So on behalf of Anil, sir, I'm presenting this national guidelines in the management of drug-resistant TB. So clinical updates and treatment protocols. So in the dual burden, global versus in India. So 26% of the global TB incidence in India is 28 lakhs. That is 199 TB cases per lakh. So globally, 1.08 crores patients are there. So mortality, if you see in HIV also, so of the global is 29%. In India, 315 patients have been died due to this HIV negative cases. So 9.6 patients incidence is in HIV positive cases, and 27% of global MDR cases are there. So in India is 1,10,000 cases are presently there. So evolution of threat and response. So the resistance spectrum has been wider now because we used to, before 15 years, 10 years back, there were only TB and MDR TB. Now there are many sections are there, H monopoly drug resistant TB, that is only for one drug, that is INH, excluding rifampicin. And then we called MDR TB, including rifampicin with INH resistance. And then pre-XDR TB, that is MDR TB plus fluoroquinolone resistance. Then XDR TB, pre-XDR TB plus the other second line drugs, linezolid or bedaquiline resistance. So the diagnosis by solid culture DST specific labs in 2007, introduction of CBNAT, that is cartridge-based nucleic acid amplification assay test. So this is a bedaquiline and dolaminate have been introduced. So nationwide coverage. Sorry, I couldn't. So nationwide coverage of universal DST, that is UDST we call. So before starting the first line drugs, we used to test all the drugs, that is UDST. So to see the response of resistance. The present era, there is a newer regimen has come up. So we used to treat MDR treatment for 18 to 20 months. Now the newer regimen has come up for 6 months to 9 months, the BPAL-M regimen with very few drugs. So the integrated diagnostic algorithm, that is the presumptive TB, that is suspect of TB, abnormal and non-responders. If MTB is positive, yes, we can see the resistance of the rifampicin in CBNAT. So in CBNAT, rifampicin is resistance is detected to evaluate for BPAL-M, shorter oral or longer oral MD or XDR regimens. If rifampicin is not detected, so start first line treatment and we send it for LPA line probe assay to see INH resistance. So if INH resistance is detected, so we call it as H monopoly drug resistant TB. So if INH is not detected, so standard first line drugs we introduce, that is 2 months INH, rifampicin, pyrazinamide and ethambutol, and another continuous phase for 4 months INH, rifampicin and ethambutol. So these are the treatment protocol for first line, and precision of diagnostic baseline liquid culture DST policy. So baseline liquid culture DST is strictly required for all the drug resistant specimens. So targeted drug for liquid culture DST is moxifloxacin, linezolid, pyrazinamide, bedaquiline, protonamide, dolanomide. So clinical protocol initiate treatment based on NAT, MTB, RIF, XDR and LPA to modify regimen based on liquid culture. So these results immediately upon the availability. The foundation of pre-treatment protocols. So in DRTB, for the pre-treatment protocol, clinical evaluation is mandatory. So mandatory baseline laboratory investigation we do CBC, LFT and KFT. And ECG screening for QTCF baseline. The visual acuity and color vision baseline crucial for upcoming linezolid usage. So DRTB counseling tool pillars, so education, nature of disease, that is lab results and importance of adherence. Hygiene and diet is very important. Cough etiquette, intensive nutritional support is also very much needed. Support system, enrollment of Nikshay Poshan Yojana. So we have a portal called Nikshay. So in that Nikshay Poshan Yojana, for the patients who were diagnosed TB, whether it is BPL or APL, the government of India is paying for all now 1,000 rupees per month to the TB patients for their nutritional supplements and for their transportation and the other expenses. So psychological support to addressing stigma, de-addiction for alcoholic, chronic alcoholics, intervention and family plannings. The new gold standard is BPALM regimen, a blueprint administered orally with food and water. The pill box contain bedaquiline. Weeks 1 to 2 weeks, we give 400 milligrams daily, and week 3 we give 200 milligrams 3 times a week. And another drug is protenamide, 200 milligrams once daily. So linezolid is 600 milligrams once daily, and moxifloxacin, so 400 milligrams once daily. So then pyridoxine supplementations. So according to the age, 50, 100 and 100 milligrams, we start along with this regimen. So managing linezolid toxicity and ADRs. So bone marrow suppression, optic neuritis. So mandatory monitoring protocols, hematological CBC with hemoglobin, platelets, and day 15, day 30, then strictly monthly until 6 months. So increase frequency if the clinical indicated. So ophthalmic visual acuity and color vision, week 9, week 13, and week 26. So cardiological ECG for QTCF and day 15, day 30, then 2 months, 6 months. So if baseline QTCF is more than the 450 to 500, the in males the 470 to 500, female perform daily ECG for initial 3 days. The specialist intervention, immediate ophthalmical neurological consultation as clinically indicated upon the suspected ADRs. So alternative is 9 to 11 months shorter oral regimen. So for the alternative for the BPAL regimen, so if it is that is not advisable, so 9 to 11 months shorter oral regimen, so preferred or over the longer regimen for the children with MDR or TB. The strict eligibility criteria is RRTB if detected, phenoxylamine resistance is not detected, no prior second line drug exposure more than 1 month. So no extensive and severe extrapulmonary disease. For this criteria, we prefer 9 to 11 months shorter oral regimen. So the intensive phase is 4 to 6 months. That is linezolid, levofloxacin, clofazimine, pyrazinamide, ethambutol, high dose of INH and bedaquiline. So for 5 months, levofloxacin, clofazimine, so pyrazinamide and ethambutol. So we omit bedaquiline after 6 months. So note that linezolid can be used even if both CAT-G and INHA mutations are present. So these mutations we will look into the LPA tests. So for alternative other regimen is 18 to 20 months longer oral for XDR TB. So initiated when B-palm or shorter regimens are ruled out due to the ineligibility and additional resistance or intolerance. So base regimens are 6 months bedaquiline and 18 to 20 months levofloxacin, linezolid, clofazimine, and cycloserine. Here, the replacement logic is if levofloxacin or pyrazinamide cannot be used, then replace with linezolid. If linezolid cannot be used, then replace with clofazimine plus cycloserine. So if both levofloxacin and pyrazinamide cannot be used, add two drugs from the linezolid, clofazimine, cycloserine based on susceptibility and tolerance. If resistance is detected, switch to B-palm or shorter regimen if eligible. So these are the alternative regimens. For H monopoly, only the INH resistance is detected. So standard regimen will be 2 HRZE and 4 HRE is failing or insufficient due to H resistance. The new prescription pathway is 6 to 9 months levofloxacin, rifampicin, ethambutol, and pyrazinamide. So if H resistance is detected. So these are the regimen selection matrix. If we start B-palm regimen 6 to 9 months, this is for pre-XDR, MDR, RRTV. Key inclusions are extensive extrapulmonary. The core drugs are bedaquiline, protanamide, linezolid, and moxiflux. Shorter oral 9 to 11 months, less than 14 years children, no fluoroquinolone resistance is detected, and prior to second line exposure more than 1 month. That is linezolid, levofloxacin, clofazimine, pyrazinamide, ethambutol, high dose of INH and bedaquiline. So longer oral 18 to 20 months, ineligible for B-palm, shorter complex resistance. So or susceptibility, rifampicin susceptibility TB, that is bedaquiline plus levofloxacin, linezolid, clofazimine, and cycloserine. So for H monopoly, 6 to 9 months, H resistance only and R resistance is detected. So levofloxacin, rifampicin, ethambutol, and pyrazinamide will start. So these are the regimens. So the recent regimen is B-palm regimen, which will replace longer oral for 18 to 20 months to 6 to 9 months. So the better results are we are seeing now. So maybe patient acceptability is also there. So active treatment monitoring timeline. So that is week 0 microscopy we do. So after 15 days smear microscopy, CBC, ECG. So these are the monitoring for weeks to months in B-palm regimen. So the ECG is mandatory because we give bedaquiline. It's a diaryl family of this thing. So it's a make cardiac arrhythmias. So we used to monitor ECGs every continuously. So long-term follow-up protocols to ensure recurrence-free survival. We have 4 follow-ups are there for 6 months, 12 months, 18 months, and 24 months. So clinical reviews, X-ray, smear, culture and AST. So evaluation whenever the patient returns to health system. So surgical evaluation window assess for surgical intervention only after culture conversion has been achieved. So precision is a paramount universal liquid culture DST is the non-negotiable anchor of modern PMDT. The new Vanguard BPALM is a primary weapon for eligible DRTB patients. So relentless vigilance, strict monitoring of prevents toxicity and stops XTR escalation in its tracks. So, so we end finally TB हारेगा देश जीतेगा. So this is about um, treatment guidelines of drug-resistant TB. Thank you.
Thank you so much, sir. So that was a highly informative session on MDR TV, and we truly appreciate the clarity you brought to the topic. Thank you so much, sir. And sir, shall we take up any questions from the attendees?
I'm calling Anil if he is joining shortly. Sir,
Sure, sir. Sure, sir.
he is joining now.
Sir.
Sir, yes, sir. Sir,
Welcome, sir.
Veerbhadra
Dr.
sir is
Anil,
there.
sir. Welcome.
Thank you. Thank you.
How are the things, sir?
She's admitted. I am with her in Apollo.
Yeah.
I'll admit on the 10 minutes. I thought Sanath called me. I thought I'll take some questions if it is there.
Yes, sir. It's very kind of you, sir, for
Thank you,
joining
sir.
us. Very
Thank you,
kind
sir.
of you. Hope for the best and hope she'll recover
Yeah, thank
fast.
you. Thank you.
Jaspal?
Good evening, Anil, sir.
Yeah, Shreya, head.
Yes, sir. I welcome Anil, sir, and we would like to take up questions, sir. Is that fine?
Yes,
Yeah.
ma'am.
Yeah.
Yes, sir. All the attendees, whoever has any questions, they can unmute yourself and ask the questions.
Sir, Anil, sir, where do we stand, the Karnataka in MDR cases?
Sir, if I take MDR is different, but if I speak of drug-resistant TB, which includes INH resistance, we have somewhere around 5% of the TB patients are drug-resistant TB patient. Particularly if we are speaking of multi-drug resistant TB, it is around 2.8 to 3%.
Hello,
Yes, sir.
Dr. Anil.
Yes, sir.
What are the investigations for this extra pulmonary tuberculosis, especially abdominal tuberculosis?
Sir, there are two things that we do, sir. One is histopathology. The other is biopsy followed by liquid culture.
Liquid culture, okay.
Sir, we don't, in fact, all those precious samples that are there, sir, we usually recommend liquid culture because if we use up the tissue for NAT test, then the NAT comes as MTB detected. Then we will not have any sample to escalate it to culture or LPA. So what the standing instruction that is given to the districts is any precious sample that is collected, they should put it for liquid culture. Once the growth comes, then we'll be able to do a drugogram for all the drugs that is requested, and then appropriate treatment can be started. In the meantime, for Based on the histopathology report, the patient can be started on drug susceptible TB, sir. Most of the time in Karnataka, 97% of the TB patients are drug susceptible TB. So, keeping that analogy, we can start on drug susceptible TB. Once the DST report comes, we can switch the regimen.
Okay, sir. So recently, one lady aged about 62 years came with ascites. We tapped and sent for ascitic fluid analysis as well as CA-125. And ascitic fluid analysis came as a tuberculosis. But CA-125, it shows 5,600 something. So more in favor of ovarian malignancy.
Sir, one of the most common opportunistic infection in malignancy is TB, sir.
Ah.
It is not that one person, one disease. We've seen esophageal CA stage 4 with TB, adenocarcinoma of the lung with TB.
Oh,
So that is a possibility, sir.
both.
And when MTB is detected by NAT, then it is 100% TB.
Oh.
Because the NAT sensitivity for ascitic or pleural fluid is as low as 28%. So if you are able to pick up MTB complex on NAT, so it is sure that it is TB and treatment will help.
Okay, sir. Okay. So then we can think of both
Yes, sir. Yes, sir. Yes, sir.
as so now ovarian carcinoma also.
Yes, sir.
So, thank you, sir. Thank you.
Thank you, sir.
ಸರ್ CB NAT ಟೆಸ್ಟ್ಗಳು ಆಗ್ತಾ ಇಲ್ಲ.
ಹೌದು ಸರ್, CB-NAT ಯೂಶುವಲ್ ಆಗಿ ಗವರ್ಮೆಂಟ್ ಆಫ್ ಇಂಡಿಯಾ ಸಪ್ಲೈ ಕೊಡ್ತಾ ಇತ್ತು. ಆಲ್ ಆಫ್ ಎ ಸಡನ್ ಇನ್ ಅಕ್ಟೋಬರ್ ನವೆಂಬರ್ ದೇ ಸ್ಟಾಪ್ಡ್, ಕೊಟ್ಟಿಲ್ಲ. ಸೊ ವಿ ಹ್ಯಾಡ್ ಫ್ಯೂ ಕ್ಯಾಟ್ರಿಜಸ್ ವಿತ್ ಅಸ್, ಅದನ್ನ ನಾವು ಮ್ಯಾನೇಜ್ ಮಾಡಿದ್ವಿ. ಈಗ 20,000 ಇದೆ, ಎಲ್ಲ 20 + 20 + 10 50,000 ಬಂದಿದೆ. ಸೊ ಪ್ರೆಷಿಯಸ್ ಸ್ಯಾಂಪಲ್ಸ್ಗೆ ಯೂಸ್ ಮಾಡಿ ಅಂತ ಕೊಟ್ಟಿದ್ದೀವಿ. ಬಟ್ ವಿ ಹ್ಯಾವ್ ಸರ್, in the sense, Karnatakadalli we have 170 CB-NAT machines, but we have 473 TrueNAT machines. TrueNAT, I have 1 lakh chips with me. So, districts ge ellargu we have given standing instructions that ಎರಡು shift ಅಲ್ಲಿ TrueNAT ಮಾಡಿ, we will give TrueNAT chips ಅಂತ. I think Karnataka will sort out this issue in 20 to 30 days time. We will be getting more than 2 lakh ಸ್ಟೇಟ್ ಇಂದ ಪ್ರೊಕ್ಯೂರ್ ಮಾಡ್ತಾ ಇದೀವಿ. ದೆನ್ ಥಿಂಗ್ಸ್ ವಿಲ್ ಬಿಕಮ್ ನಾರ್ಮಲ್, ಸರ್.
ಸರ್, ನಂದು ಒಂದು ಅಬ್ಸರ್ವೇಷನ್, ಬಿಕಾಸ್ ಐ ಆಮ್ ವರ್ಕಿಂಗ್ ಇನ್ ಅ ವೆರಿ ರಿಮೋಟ್, ಅಂದ್ರೆ ಇನ್ ದ ಸೆನ್ಸ್ ಸಿರುಗುಪ್ಪ ಅನ್ನೋ ತಾಲೂಕಲ್ಲಿದ್ದೀನಿ. ಆಕ್ಟಿವ್ ಕೇಸ್ ಫೈಂಡಿಂಗ್ ಅಲ್ಲಿ ಟಾರ್ಗೆಟ್ ಕೊಟ್ಟಿರ್ತೀರಲ್ಲ ಸರ್, ACS ಅಲ್ಲಿ, ಅಲ್ಲಿ ನನ್ನ ಅಬ್ಸರ್ವೇಷನ್ ಪ್ರಕಾರ ಸರ್, ಈ ಫೀಲ್ಡ್ ವರ್ಕರ್ಸು ಟಾರ್ಗೆಟ್ ರೀಚ್ ಮಾಡ್ಬೇಕಂತ ಹೇಳಿ ಮೊದಲು CB-NAT ಕಾರ್ಟ್ರಿಡ್ಜ್ಗಳು ಏನಿದ್ವಲ್ಲ ಅದನ್ನ ಸೊ ಓವರ್ ಯೂಸ್ ಮಾಡ್ಬಿಟ್ರ ಅಂತ ಒಂದು. ಯಾಕಂದ್ರೆ ಹೌಸ್ ಹೋಲ್ಡ್ಗೆಲ್ಲ ಹೋಗಿ ಮಾಡ್ಬೇಕಂದಾಗ ಈ ಕಾಫ್ ಇದ್ದವರು ಪಾಪ ಟಿಪಿಕಲಿ ದೇ ವಿಲ್ ಗಿವ್ ದ ಸ್ಪೂಟಮ್. ಬೇರೆಯವರಲ್ಲಿ ಏನ್ ಮಾಡ್ತಾರೆ?
ಹೌದು, ತಾವು ಹೇಳ್ತಾ ಇರೋದು ಕರೆಕ್ಟ್ ಆಗಿ ಇದೆ. ಏಕೆಂದ್ರೆ ಗೌರ್ಮೆಂಟ್ ಆಫ್ ಇಂಡಿಯಾ ತುಂಬಾ ಇನ್ಸಿಸ್ಟ್ ಮಾಡೋದು ಅಂದ್ರೆ ನಮ್ದು
ಸ್ವಲ್ಪ ಕಟ್ ಆಗ್ತಿದೆ ಸರ್ ವಾಯ್ಸ್.
ಸರ್, ಈಗ ಕೇಳಿಸ್ತಾ ಇದೆಯಾ?
ಈಗ ಕೇಳಿಸುತ್ತೆ ಸರ್, ಈಗ ಕೇಳಿಸುತ್ತೆ
ಸರ್. ಅದು 3,000 ಪರ್ ಲ್ಯಾಕ್ಗೆ ಇನ್ಕ್ರೀಸ್ ಮಾಡಿದ್ರು. ದಟ್ ವಾಸ್ ದ ಟೈಮ್. ಆಮೇಲೆ ದೇ ಅಪ್ಫ್ರಂಟ್ NAT, ಕರ್ನಾಟಕ ವಾಸ್ ಆಲ್ವೇಸ್ ಏಮಿಂಗ್ ಫಾರ್ ಅಪ್ಫ್ರಂಟ್ NAT. ಹಾಗಾಗಿ ಸ್ವಲ್ಪ ಟೈಮಲ್ಲಿ ಓವರ್ ಯೂಸ್ ಆಯ್ತು. ಬಟ್ ವಿ ಹ್ಯಾಡ್ ಸರ್, ನಾವು ಸ್ಟೇಟ್ ಇಂದಾನೆ ಒಂದು 3 ಲಕ್ಷ ಕ್ಯಾಟ್ರಿಡ್ಜ್ ಕೊಂಡ್ಕೊಂತ ಇದ್ವಿ. ಗೌರ್ಮೆಂಟ್ ಆಫ್ ಇಂಡಿಯಾನು ಬರೋದು. ದಿಸ್ ಇಸ್ ಅ ನ್ಯೂ ಥಿಂಗ್. ಲೈಕ್ ಇಟ್ ವಾಸ್ ಆಲ್ ಆಫ್ ಎ ಸಡನ್ ನಮ್ಗೆ ಶಾರ್ಟೇಜ್ ಆಗಿದ್ದು. ಈ ಸರ್ತಿ ವಿ ಆರ್ ರಾಷನಲೈಸಿಂಗ್ ದ ಯೂಸ್ ಆಫ್ NAT cartridges. ಸರ್, ಒನ್ ಥಿಂಗ್ ದಟ್ ಐ ವಾಂಟೆಡ್ ಟು ರಿಕ್ವೆಸ್ಟ್ ಇಲ್ಲಿ ಏನಂದ್ರೆ, ಲೈಕ್ ವಾಟ್ ಎವರ್ ವಿ ಡೂ ಸರ್, ನಮ್ಮಲ್ಲಿ ಇಫ್ ಐ ಹ್ಯಾವ್ ಟು ಬ್ರಿಂಗ್ ಡೌನ್ ಇನ್ಸಿಡೆನ್ಸ್ ಆಫ್ TB, the one thing was vaccine, BCG vaccine ಕೊಟ್ಟಿದ್ದೀವಿ. ಇಟ್ ವಿಲ್ ಟೇಕ್ another 2 years, 3 years for us to get the result. ಬಟ್ TB ಪ್ರಿವೆಂಟಿವ್ ಥೆರಪಿ ಅಂತ ಏನು ನಾವು TB ಪ್ರೊಫೈಲಾಕ್ಟಿಕ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡ್ತೀವಿ, that has helped Karnataka a lot in bringing down incident TB. We are seeing this in the pediatric age group, we are seeing this in the HIV group. ಸೊ ಈಗ ಹೌಸ್ ಹೋಲ್ಡ್ ಕಾಂಟ್ಯಾಕ್ಟ್ಸ್ಗೂ ಕೊಡ್ತಾ ಇದ್ದೀವಿ. ಹಾಗೇನೆ ಇಲ್ಲಿ IMA ಯಾರಾದರೂ ಲೈಕ್ ಹೈ ರಿಸ್ಕ್ ಗ್ರೂಪ್ಸ್ ಟ್ರೀಟ್ ಮಾಡೋವಂಥವ್ರು, ತಾವು ಮ್ಯಾಲಿಗ್ನೆನ್ಸಿ, ಆರ್ಗನ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್, ಲಾಂಗ್ ಟರ್ಮ್ ಸ್ಟಿರಾಯ್ಡ್ಸ್, ಆಲ್ಫಾ TNF ಆಲ್ಫಾ ಆಂಟಾಗೋನಿಸ್ಟ್, ಇವರೆಲ್ಲ ತಗೊಳ್ತಾ ಇರೋರಿಗೆ ಆಫ್ಟರ್ ರೂಲಿಂಗ್ ಔಟ್ ಆಕ್ಟಿವ್ TB, ಇಫ್ ಯು ಆರ್ ಗಿವಿಂಗ್ TPT, the protection rate is 60 to 90% for a period of 5 years. ಸೊ ಅದನ್ನ ಈ ವರ್ಷ ವಿ ಆರ್ ಪ್ಲಾನಿಂಗ್ ಟು ಯೂನಿವರ್ಸಲೈಸ್ ಇಟ್ ಅಂಡ್ ದೆನ್ ಕಂಟಿನ್ಯೂ TPT ಅಂದ್ರೆ ಲಾರ್ಜ್ ಸ್ಕೇಲ್ TPT ಕವರೇಜ್ ಫಾರ್ ದ ನೆಕ್ಸ್ಟ್ 2 years, so that by 2028 we will see a dip in the number of TB patients.
ಸರ್ ಏನ್ ಹೇಳಿದ್ರಿ ಸರ್? BCG ವ್ಯಾಕ್ಸಿನ್ ಅದು
BCG ವ್ಯಾಕ್ಸಿನ್ ಆಯ್ತು, ಅದು ಟ್ರಯಲ್ ಸ್ಟಡಿ ಇತ್ತು ICMRದು, ಅದು ಮುಗಿಸಿದ್ವಿ. TB preventive therapy is very important, sir. It is a very important activity for us.
ಪ್ರೋಟೋಕಾಲ್ ಏನ್ ಸರ್? ಅಂದ್ರೆ what exactly you give?
How there are, we have what is called as IGRAs anta, IGRA,
IGRA test,
interferon gamma releases, or CYTB anta bandide. ಸೊ CYTB ಇರೋದ್ರಿಂದ ಅದನ್ನ ಸ್ಕಿನ್ ಟೆಸ್ಟ್ ಬ್ಯಾಂಟು ತರಾನೆ, ಅದು ಪಾಸಿಟಿವ್ ಬಂದ್ರೆ TB ಪ್ರಿವೆಂಟಿವ್ ಥೆರಪಿ ಹಾಕ್ತೀವಿ ಸರ್ ನಾವು.
That is only true drugs ಅಲ್ಲ ಸರ್?
Yeah. INH and rifampicin once a week for 12 doses.
Okay.
Any more questions?
ಸರ್ ಒಂದು ರಿಕ್ವೆಸ್ಟ್ ಸರ್, ತಾಲೂಕು ಮಟ್ಟದಲ್ಲೂ ಮತ್ತು ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಮಟ್ಟದಲ್ಲೂ ಸ್ವಲ್ಪ ಓರಿಯಂಟೇಶನ್ ಆಗ್ಬೇಕು ಸರ್ ನಮ್ಮ IMA ಪರವಾಗಿ. IMA ಇದಕ್ಕೆ
ಮಾಡೋಣ ಸರ್. ನಮ್ಮ ರೆಸ್ಪೆಕ್ಟಿವ್ ಡಿಸ್ಟ್ರಿಕ್ಟ್ TB ಆಫೀಸರ್ಸ್ ಹೇಳ್ತೀನಿ ಸರ್.
On a continuous basis it should happen, because sir, one thing that I observed is, like, for no disease there is a specific very what you call dedicated team by the government. It is only for tuberculosis we have a team like this.
Yes sir.
ಅಲ್ವಾ? ಬೇರೆ ಬೇರೆ ಡಿಸೀಸ್ಗಳಿಗೆಲ್ಲವೂ ಇಟ್ ಇಸ್ ಅ ಪಾರ್ಟ್ ಆಫ್ ದಿ ಮೆಡಿಕಲ್ ಪ್ರೊಫೆಷನ್. ಬಟ್ ಇದು ತಾಲೂಕಾ ಲೆವೆಲ್, ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಲೆವೆಲ್, ಎಕ್ಸ್ಕ್ಲೂಸಿವ್ ಟ್ಯೂಬರ್ಕ್ಯುಲೋಸಿಸ್ ಆಫೀಸರ್, ವಿಜಿಲೆಂಟ್ ಆಫೀಸರ್, ಲ್ಯಾಬ್ ಟೆಕ್ನಿಷಿಯನ್, a separate machine and a separate culture lab. Everything is so meticulous and very dedicated team for one single disease. It is only tuberculosis.
ಸರ್ ನಾನು ರಿಕ್ವೆಸ್ಟ್ ಮಾಡ್ತೀನಿ ಎಲ್ಲ ಡಿಸ್ಟ್ರಿಕ್ಟ್ TB ಆಫೀಸರ್ಸ್ಗೆ, ಲೈಕ್ IMA ಯಾವಾಗ ಟೈಮ್ ಕೊಡುತ್ತೋ ಅವಾಗ
ಸರ್ ಏನ್ ಟೈಮ್
ಶಾರ್ಟ್ ಸೆಷನ್ ಸರ್.
ಸರ್ ಏನಿಲ್ಲ, ನಮ್ಮ ಅಧ್ಯಕ್ಷರು ಇಲ್ಲೇ ಇದ್ದಾರೆ, ಸೂರ್ಯರಾಜು ಸರ್ ಇಲ್ಲೇ ಇದ್ದಾರೆ. ಒನ್ ಡೇ ಫಿಕ್ಸ್ ಮಾಡ್ಬಿಟ್ಟು ನಮ್ದು ಹೆಂಗಿದ್ರು ಈ ಝೂಮ್, ಯಾಕಂದ್ರೆ ತುಂಬಾ ವೈದ್ಯರುಗಳು ಎಲ್ಲರೂ ಅವರವರ ಪ್ರೊಫೆಷನ್ ಅಲ್ಲಿ ಬ್ಯುಸಿ ಇರ್ತಾರೆ ಸರ್. ಈಗ ಸೊ ಆ ಕಾರಣದಿಂದಾಗಿ ನಮ್ದು ಐ ಕ್ಯಾನ್ ರಿಕ್ವೆಸ್ಟ್ ಅವರ್ ಪ್ರೆಸಿಡೆಂಟ್ ಅಂಡ್ ಸೆಕ್ರೆಟರಿ ಟು ಡೆಡಿಕೇಟ್ ಒನ್ ಡೇ ಫಾರ್ ಒನ್ ಜಿಲ್ಲಾ ಥ್ರೂ ದ DHO ಅಥವಾ DTO. They can be in touch with and have communication with that respective district. What are the things that are happening ಅಂತ. ಯೂಶಲಿ ಏನಾಗುತ್ತೆ ಸರ್, ಪ್ರೈವೇಟ್ ಪ್ರಾಕ್ಟೀಷನರ್ ಸರ್ ನಮ್ಮಂಥವ್ರಿಗೆ ಅಲ್ಲಿ ಏನಾಗ್ತಿದೆ ಅಂತ ಗೊತ್ತಾಗಲ್ಲ.
ಸರ್ ಮಾಡ್ತೀವಿ ಸರ್, ನೋ ಪ್ರಾಬ್ಲಮ್ ಸರ್.
ಈ ಝೂಮ್ ಪ್ಲಾಟ್ಫಾರ್ಮ್ ಸಿಗುತ್ತೆ ಸರ್, ನಮಗೆ ಆರಾಮಾಗಿ ಸಿಗುತ್ತೆ. ಸೊ ದೇ ಕ್ಯಾನ್ ಯುಟಿಲೈಸ್, ಐ ಫೀಲ್.
ವಿಲ್ ಅರೇಂಜ್ ಸರ್, ನೋ ಪ್ರಾಬ್ಲಮ್ ಸರ್.
ಎಸ್ ಸರ್,
ಆಗ್ಬೋದಲ್ವಾ ಸರ್?
ಡೆಫಿನೆಟ್ಲಿ ಸರ್,
ಆಗುತ್ತೆ ಸರ್, ಮಾಡೋಣ.
ಒನ್ ಡೇ ಫಿಕ್ಸ್ ಮಾಡ್ಬಿಡಿ ಸರ್. ಇಟ್ ಈಸ್ ಫಾರ್ TB, ದಟ್ ಡೇ TB ಫಾರ್ ಸಮ್ ಡಿಸ್ಟ್ರಿಕ್ಟ್, ಸಮ್ ಒನ್ ಟಾಪಿಕ್ ಒಂದೊಂದೊಂದು ನಿರಂತರವಾಗಿ ಮಾಡ್ಕೊಂಡು ಹೋಗೋಣ ಸರ್.
ಓಕೆ ಸರ್, ಓಕೆ ಸರ್.
ಸನತ್
ಸರ್ ನಮಸ್ಕಾರ.
ಸರ್ ಹೇಳಿ ಸರ್.
ಯು ಹ್ಯಾವ್ ಟು ಟೇಕ್ ಎ ಲೀಡ್ ಸನತ್.
ಸರ್ ಡೆಫಿನೆಟ್ಲಿ ಸರ್.
ನಾವು ಮಲಗಿರ್ತೀವಿ, ಎಚ್ಚರಿಸಪ್ಪ.
ಇಲ್ಲ, ಆಕ್ಚುಲಿ ಎವ್ರಿ ಡಿಸ್ಟ್ರಿಕ್ಟ್, ಎವ್ರಿ ತಾಲೂಕಾ ವಿ ಆರ್ ಡೂಯಿಂಗ್ ದಿಸ್, ಬಟ್ ಪ್ರಾಬ್ಲಮ್ ಏನಂದ್ರೆ ದ ಟೈಮ್ ನಮ್ಗೆ ಕೊಡೋದು ಬಹಳ ಕಡಿಮೆ. ಸೊ ಈವನ್ we go for the CMS, IMS, CMS ಇದ್ದಾಗ last on 15 minutes ಕೊಟ್ರು we can give our inputs. ಯಾಕಂದ್ರೆ ನಾವು ಬರೀ ಟಿಬಿ ಅಂದ್ರೆ ಬಹಳ ಸ್ವಲ್ಪ ಕಷ್ಟನೇ ಸೇರೋದು. ಸೊ ಅಲಾಂಗ್ ವಿತ್ ಅದರ್ ಏನು CMS ನಡೀತವೆ. ಸೊ ದೇರ್ ವಿ ಕ್ಯಾನ್ ಸ್ಟ್ರೆಸ್ ಅವರ್ ಟಿಬಿ ಪ್ರೋಗ್ರಾಮ್.
ಇಲ್ಲ, ಎಕ್ಸ್ಕ್ಲೂಸಿವ್ ಆಗಿ ಮಾಡ್ಬಿಡಿ. ಅಂದ್ರೆ IMA ಇಂದ ವೆಬಿನಾರ್ ತರದ್ದು ಒಂದು ಸೀರೀಸ್ ಮಾಡ್ಬೋದು. ನಮ್ಮ ಸಿರುಗುಪ್ಪ ತಾಲೂಕು IMA ಇಂದ ನಾಳೆ ವಿ ಆರ್ ಹಾನರಿಂಗ್ ಆಲ್ ದ ಲ್ಯಾಬ್ ಟೆಕ್ನಿಷಿಯನ್ಸ್ ಅಂಡ್ ಈ ಟ್ಯೂಬರ್ಕ್ಲೋಸಿಸ್ ನಿಯಂತ್ರಣಾಧಿಕಾರಿ, ಪ್ರಯೋಗಶಾಲಾ ತಂತ್ರಜ್ಞ ಅವರೆಲ್ಲರನ್ನು 16 ಪೀಪಲ್ ವಿ ಆರ್ ಹಾನರಿಂಗ್ ಫಾರ್ ದೇರ್ ವೆರಿ ಗುಡ್ ವರ್ಕ್.
ಇಟ್ಸ್ ಎ ವೆರಿ ಗುಡ್ ಗೆಸ್ಚರ್ ಸರ್.
ಎಸ್, DHO ಹೇಳಿದ್ದೀನಿ, DTO ಇಂದ್ರಾಣಿ ಮೇಡಮ್ ಹೇಳಿದ್ದೀನಿ, ದೇ ಆರ್ ಕಮಿಂಗ್.
She is very much committed.
Yeah, we are involving PDOs also. We have requested them to come and attend because they are the policy makers at ground ಇದರಲ್ಲಿ. ಅವ್ರಿಗೂ ಒಂದು ಓರಿಯಂಟೇಷನ್ ಕೊಡ್ಬೇಕಂತೇಳಿ ನಮ್ಮ DHO ಹೇಳಿ, I am purely a private practitioner but involved with them. Really they are doing good job.
Yes, sir.
Sir, Dr. Anil sir and Dr. Suryaji, urologist.
Sir.
What is the reason, sir, why tuberculosis is one disease which we are not able to completely control and eradicate from our country, when most of the diseases like, poliomyelitis and many things we completely eradicated? Is it one of the reason is contact tracing, sir?
Sir, contact tracing, sir. The problem is no effective vaccine, sir.
Okay.
And second thing is there is no definite investigation for latent TB, sir.
Yes.
And a good drug for latent TB. Ideradu sikkidre,
Yes, sir.
overnight we can control and eliminate TB. So now what we are seeing is by the time they come, they would have gone to 3-4 places. Then they would have given the disease to so many people before they are diagnosed and treated. Second thing is the duration of treatment. So now at least, previously when we started our careers, 78% of the TB patients would drop the medications just like that. Now it has come down to 1 to 2%. So these are the two main reasons, sir, that we can think of. Otherwise, and all these days the challenge was in diagnosis itself, because relying greatly on microscopy. Now at least we have upfront NAT, the diagnostic algorithm has changed. We have added X-ray to it. So now you will be seeing some change in the burden of TB being, it will come down. What I see is over the years, when I look at the TB burden of TB, 70% of the TB patients would come from rural area, and 30%, 35% used to be from urban areas. Now it is rural TB is coming down because the access has improved. There is quality of treatment. A lot of people access public health care, and there is a definite mechanism of referral. But we are seeing a surge in urban TB, lot of migration, no access to health care. So we are seeing TB in urban areas, and now we are re-strategizing how to reach and how to act in the urban areas. In the next 5 years, sir, you will definitely see further reduction in the burden of TB in our country. And Karnataka also, by 2030, our aim is all the districts in Karnataka should have the incident TB of less than 100 per lakh, and at least 50% of the district should have incident TB of less than 60 per lakh per year. So that is how we have planned our activities.
Sir, I have one question which is there in the chat box. What is the real ground level problem of tuberculosis control in India? What is the status, sir, right
Sir,
now?
yes, sir. The biggest problem that we have is the population at large, sir.
Yes.
So we are having, and if I look at the ground level problem, one is the reach. Uh, we, though we have so many workers, all those things are there, but then when I look at the population of 150 crores, reaching out to them and uh, converging all the departments into one activity, so that has always remained a challenge. Second thing is TB, sir, it is not like dengue or COVID. Last a year or year and a half back, you would have seen every newspaper carried about dengue. But
Yes.
TB kills more people, but nobody writes about TB.
Correct.
Unless TB, it's a neglected epidemic.
Oh,
One maternal death, all of you are called to DC's chamber to give explanation. Here, 4,000 people die out of TB, nobody is bothered.
okay.
So, unless that political and administrative seriousness chips in and the government owns TB program, then it can go to the next level.
Is there any single, spot test for tuberculosis, sir? Because that will
It
change.
will come, sir.
Yes.
The many tests are in the pipeline, sir. It will come, sir.
Okay.
Even with the people are working on blood-based tests now, sir. They are working on heat shock proteins and some enzymes that are released during the acute phase, called as acute phase reactants. They are working on it. IIC is also working on few of the molecules. Probably in a year or two, all the NATs, everything will go away. We will be, as you said, we will have something like HIV, lateral flow assay, something like that may come, sir, for TB.
Yes.
Sir,
Good
good
evening,
evening, sir. Okay, Kirtana, please go ahead. Hello.
Sir, good
Yes.
evening. This is Srinidhi.
Yes, sir.
Sir, I'm a final year MBBS student, sir. Sir, I have a question, sir. Like many patients with persistent cough, initially they'll take OTC drugs, sir. They'll go to the medical shop, which is common nowadays. They'll Google the medications through the AI or the Google, and then go to the medical shop and take the medication. Sir, does it contributing in delaying the elimination of TB? This is my first question, sir. Second question is, like, as a young clinician, sir, who are going to enter an internship, or a young clinician, what is one advice you will suggest us to not like try to avoid that mistake in diagnosing and managing TB, sir?
Yeah, two good questions. First thing is, I partially agree with you that OTC is there, but in Karnataka, we have trained all the pharmacists on this. Uh, and all those pharmacists, if they come across patients with chronic cough, they will refer people for sputum microscopy. So we have, I can speak about Bangalore in JJR Nagar, uh, which is there. All the pharmacists refer them to the nearest hospitals for TB management. Even the chain, like the Apollo Pharmacy or the other pharmacy, they also, if they say they have cough, they will give the drugs, but they'll say, go and show to the doctor. So, but like the delay is there. We have done a study in Bangalore which says that before the TB patient is diagnosed as TB, he would have gone to 3 care providers. So only then he would be diagnosed as TB. That I do agree with you. The second, as a young clinician, um, two things that I will tell you what should be there in your mind when you are thinking of when you are practicing. One is about the diagnosis of TB. Any person with signs and symptoms suggestive of TB, don't hesitate to ask for investigations for TB. That is one thing. The second thing is there is no empirical treatment for TB. If you think that this patient has TB, despite your microbiology tests being negative, you have tried to rule out other tests and you strongly suspect TB, go ahead and treat it as TB. Don't, like half-hearted attempts to treat TB should not be there. Second thing, most important, e- the the bottom line of TB management is never add a single drug to a failing regimen. So you see that this patient is not responding to treatment, either microbiologically or clinically. So don't ever do the mistake of just keep on replacing drugs. Like doxycycline is not acting, you go into augmentin. Augmentin is not acting, go to Monosef. Monosef is not acting, you're looking at linozolid. So that kind of adventurism should not happen in TB. So I'll give you a very small example. We had one, I don't want to name the district, or I had one young 23-year-old extrapulmonary TB. He had gone with pain in the right hip. So right hip, they diagnosed it as TB. They started him on treatment. After 1.5 months, he said, I still have pain in the right hip. So the clinician removed rifampicin and added levofloxacin. So then, like he developed swelling in the right knee. So the clinician removed levofloxacin and added cycloserine. Then he developed swelling in the right neck. He was referred. At the age of 23, he had become an XDR TB. So, and if it is drug susceptible TB, drug susceptible treatment only. There is no point in adding quinolones for drug susceptible TB. These are the 2 or 3 things, like take home messages for young doctors.
Thank you, sir. Thank you so much.
Sir, good evening, sir.
Yes, sir.
Sir, namaskara. Sanat Kumar sir, ಅವರಿಗೆ ನಮಸ್ಕಾರ. Anil Kumar sir, ಅವರಿಗೆ ನಮಸ್ಕಾರ. I am Dr. Jaspal Singh. Sir,
Yes.
the whole session went on well, even at the time of difficulty you had with switching over with Dr. Sanat Kumar. He managed the whole episode so well that we could not even get the hitch that there was some kind of a disturbance which we are going to be facing. But now I have a very, very simple question, sir. As a surgeon, I'm a general surgeon, and I've been practicing since past 25 years. In my experience, I have gone through all the slides. I have understood what Dr. Sanat Kumar sir has shown about the MDR TB and the new regimens, which include linezolid, moxifloxacin, and other things. And I definitely, have seen so many of times that we have been still going with the first line treatment with your old regimen, where INH, rifampicin, ethambutol, and all those drugs were being given. But later on, when they were not responding, we have switched to linezolid, moxifloxacin, and sometimes the patients have been really helped. But maximum I'm seeing extrapulmonary type of tuberculosis. Maybe it is related to gastroenteric type of tuberculosis, or it could be something like lymphatic system involved, where we get most of the time lymph nodes where they are turning out to be positive because the patients come with abscess, and we get to know that they are all Koch abscesses. When we want to further refer them later on, after the whole part is cleared from our side, as that we have taken the sample, we got them investigated, and the sample has come positive for tuberculosis, and then we post-operatively want them to go in for a proper treatment protocol of tuberculosis. Some of our patients who really are not well-to-do, we tell them to go to the district tuberculosis center and with our reports. what happens most of the time that because we would not have, in fact, when I get an acute neck abscess and I do an IND, I take a sample and I get it cultured and I send it for AFP staining. So many times the results come positive, but by that time I would not have taken any kind of a sputum sample, so I send them, and most of the time they are sputum negative and they don't show any pulmonary signs, and they don't get properly, they are not recognized from the centers as a subject of tuberculosis, and they don't get into the regimen what the government has to be, applying for them and come under the treatment protocol, because an abscess like report what we send with the patient to saying that you go to the district tuberculosis center and get your further treatment done. Can you highlight on this aspect? Because I have seen that some of my patients come back and saying, sir, they are not giving, so I'll continue with the drug. And most of the time, because these drugs are expensive, they don't complete treatment. They go for 1 or 2 months with the treatment with being expensive, and then they don't follow up properly.
Sir, actually, I don't know. Because the handling instructions don't use email. I does happen, then we are very sorry. We will take care of this. That no patient who's diagnosed TB, we will ensure that he gets the best medicines that is available with us, and we will ensure that he completes the treatment, sir. So we'll
Yes, sir.
take note of it, and then next time when we are reviewing our program, we'll just keep this in our mind, and then one solid instruction will go from the state office to all the districts that they, at no point they should be refusing any patient
Any
sent
patient.
by
Yes.
yes, sir. Everybody, sir. Pulmonary or
So,
extra pulmonary, will take care of it, sir.
yes, sir. It's so happening, sir, that sputums are not coming positive for such cases, because
No, sir.
we would
We
have
will not
started out.
insist, sir. We will
Yes,
not
sir.
insist, sir. I am aware
Yes,
of it. So
yes,
you've
sir.
told me, then we will not look at pulmonary TB when EPTB is already present, sir. Despite that, we will provide the treatment, sir.
Yes, sir. Oh, thank you very much, sir.
Thank you, sir.
Thanks.
Hello. Hello.
Hello. Yes, sir.
Please
Hello.
tell, sir.
Can I speak?
Sir, please introduce and
Yeah.
continue, sir. Yes.
I am Dr. Rajesh BP. I am a senior pulmonologist residing in Davangere. I am a secretary of Davangere branch. Good evening to all the office bearers of the state IMA KSB. I'm Dr. Anil.
Sir.
Yeah. I think you are into the state. Hello.
Sir, ಕೇಳಿಸ್ತಾ ಇದೆ.
ಕೇಳಿಸ್ತಾ ಇದ್ದೀರಾ? ಓಕೆ. ನಾನು ಈಗ ಮೋಸ್ಟ್ಲಿ ಟೈಮ್ ಆಯ್ತು 10:25. ಒಂದು ಕ್ವಶನ್ ಕೇಳ್ತೀನಿ. ಯಾಕೆ TB ನ ಎಲಿಮಿನೇಟ್ ಮಾಡಕ್ ಆಗ್ತಾ ಇಲ್ಲ? ಜಸ್ಟ್ ಹೈಲೈಟ್ ಫ್ಯೂ ಪಾಯಿಂಟ್ಸ್ ಸೊ ದಟ್ ಆಲ್ ದಿ ಡಾಕ್ಟರ್ಸ್ ಹೂ ಆರ್ ಸಿಟ್ಟಿಂಗ್, ಹೂ ಆರ್ ಲಿಸ್ನಿಂಗ್ ಇನ್ ದಿಸ್ ಪರ್ಟಿಕ್ಯುಲರ್ ವೆಬಿನಾರ್ ಸ್ವಲ್ಪ ಹೈಲೈಟ್ ಮಾಡಬೇಡಿ ಅಷ್ಟೇ, ಮುಗೀತು ಅಲ್ಲಿಗೆ. ಐ ಥಿಂಕ್ ಸೊ, ಬಿಕಾಸ್
Yes, sir.
ಐ ಆಮ್ ಆಲ್ಸೋ ಫೇಸಿಂಗ್, ಯು ಮೇ ಬಿ ಆಲ್ಸೋ ಫೇಸಿಂಗ್, and everybody is facing. Why we are unable to eliminate TB or eradicate TB in India?
Sir, TB, ತಮಗೆ ಗೊತ್ತಿದೆ, ಸರ್. The presentation is so very common, ಕೆಮ್ಮು. So people, when we interview patient after patient, cough is never considered as uh, a symptom for them. They find excuse.
I will just conclude. Cough ide, but people don't want to accept it as a TB. Stigma
Yes, sir.
associated with the disease. Okay.
Yes,
One,
ಎರಡು
definitely
ಸ್ಟಿಗ್ಮಾ
yes.
ಇದೆ ಸರ್. ಇನ್ನೂ
Hmm.
ಮೂರನೇದು, ದೇ ಈವನ್ ಇಫ್ ಪೀಪಲ್ ಈಗ ನಿಮ್ಗೆ TB ಇರ್ಬೋದು ಅಂತ ಹೇಳಿದ್ರು, ಆ ಬಿಲೀಫ್ ಅವ್ರಿಗೆ ಇಲ್ಲ ಬಿಡು ಅಂತ ದೇ ಕೀಪ್ ಆನ್ ಶಾಪಿಂಗ್. ಸೊ 2-3 ಪೀಪಲ್ಗೆ ಹೋಗಿ ಅಥವಾ ಅದರ್ ಸಿಂಪ್ಟಮ್ಸ್ ಮನೆಯವ್ರಿಗೂ ಇನ್ಸಿಸ್ಟ್ ಮಾಡಿದ್ಮೇಲೆ ಬರಕ್ ಸ್ಟಾರ್ಟ್ ಆಗ್ತಿದ್ದಾರೆ. ದಟ್ ಇಸ್ ಒನ್ ಥಿಂಗ್ ದಟ್ ಇಸ್ ಡ್ರೈವಿಂಗ್ ದ ಎಪಿಡೆಮಿಕ್ ಹಿಯರ್. ಅಂಡ್ ಇಲ್ಲಿವರೆಗೂ ಸರ್ ನಮ್ದು ಏನಿತ್ತು ಡಯಾಗ್ನೋಸ್ಟಿಕ್ ಕೇಪಬಿಲಿಟೀಸ್ ಕೆಪಾಸಿಟಿ ತುಂಬಾ ಲಿಮಿಟೆಡ್ ಇತ್ತು. ಮೈಕ್ರೋಸ್ಕೋಪಿಗೆ ಫಿಕ್ಸ್ ಆಗಿದ್ವಿ. ಇಟ್ ಈಸ್ ಓನ್ಲಿ ಇನ್ ದ ಲಾಸ್ಟ್ 4-5 years ವಿ ಹ್ಯಾವ್ ಅಪ್ಸ್ಕೇಲ್ಡ್ ಅವರ್ ಡಯಾಗ್ನೋಸ್ಟಿಕ್ ಆರ್ಮಮೆಂಟೇರಿಯಂ. ಇವತ್ತು ಕರ್ನಾಟಕದಲ್ಲಿ ಸರ್ 2012 ಅಲ್ಲಿ ನ್ಯಾಟ್ ಬಂದಿದ್ದು ಕರ್ನಾಟಕಕ್ಕೆ. ಟಿಲ್ 2020 ವಿ ಆರ್ ಜಸ್ಟ್ 40-50 ನ್ಯಾಟ್ಸ್. ಈಗ ವಿ ಹ್ಯಾವ್ ಆಲ್ಮೋಸ್ಟ್ 800 machines. ಸೊ ಈಗ ಸ್ಕೇಲ್ ಆಗ್ತಾ ಇದೆ. ವಿ ಕ್ಯಾನ್ ಸಿ ಸಮ್ ರಿಸಲ್ಟ್ಸ್ ನೆಕ್ಸ್ಟ್ ಸರ್.
Okay, just since you are talking about the investigation, my opinion is almost 80% of the doctors who practice doesn't know about what are the investigations are there in government regarding tuberculosis. 80% of the practicing doctors who get more number of patients than the government. They don't know what are the instruments are there in the government, what are the investigation to be done for a TB which cannot be detected properly by sputum or X-ray.
Okay.
If sputum comes negative next day, they don't have any information. This is a dark area. This is a dark area.
ನಮ್ಮಲ್ಲಿ ಇದೆ ಸರ್.
ಡಾಕ್ಟರ್ಗಳಿಗೆ ಗೊತ್ತಿಲ್ಲ ಇದೇ. ಡಾಕ್ಟರ್ಗಳಿಗೆ ಯಾರಿಗೆ ಗೊತ್ತಿಲ್ಲ. ಬಿಕಾಸ್ ಸಿ ಆಸ್ ಎ ಮೇ ಬಿ ಯು ಕ್ಯಾನ್ ಅಂದ್ರೆ ಗೊತ್ತಿಲ್ಲ. ದಾವಣಗೆರೆ ಡಿಸ್ಟ್ರಿಕ್ಟ್ TB ಆಫೀಸರ್ ಕಳೆದು ಐ ಆಮ್ ಒನ್ ಆಫ್ ದಿ ಲೀಡಿಂಗ್ ಸಿನ್ಸ್ 10 years ಹೈಯೆಸ್ಟ್ ನಂಬರ್ ಆಫ್ ಸ್ಪುಟಮ್ ಪಾಸಿಟಿವ್ ಪೇಷಂಟ್ಸ್ ನಾನು ನೋಡ್ತಿರೋದು ದಾವಣಗೆರೆಯಲ್ಲಿ. ಸೊ ನನಗೆ ರೆಫರ್ ಆಗೋದಾಗ್ಲಿ ನಮಗೆ ಕೆಲವೊಂದು ಎಷ್ಟೊಂದುಗಳು ಹೈಲೈಟೇ ಮಾಡೋದಿಲ್ಲ. What is the new instrument has come to the Chikateri General Hospital ದಾವಣಗೆರೆಯಲ್ಲಿ ಅಥವಾ ಹುಬ್ಳಿಯಲ್ಲಿ ಹುಬ್ಳಿ ಕಳಿಸ್ತಾರೆ. ಏನಿದೆ ದೇ ಡೋಂಟ್ ಅಪ್ಡೇಟ್, ದೇ ಡೋಂಟ್ ಕಮ್. ನಾನು ಇಷ್ಟು ಪೇಷಂಟ್ ಕಳ್ಸಿದ್ರು ಬರೋದಿಲ್ಲ. ದೇರ್ ಇಸ್ ಗ್ಯಾಪ್.
ಹುಬ್ಳಿಯಲ್ಲಿ ಎಲ್ಲ ಇದೆ ಸರ್. ಅದೇ ಗ್ಯಾಪ್ ಇದೆ. ಸೊ ಓಕೆ.
ಈಗ ನೀವೇ ಕಾರ್ಪೊರೇಟ್ ಹಾಸ್ಪಿಟಲ್ ಎಷ್ಟು ಜನ ಡಾಕ್ಟರ್ ಪ್ರಾಕ್ಟೀಸ್ ಮಾಡ್ತಾರೆ. ದೇ ಗೆಟ್ ಹೈ ರಿಸ್ಕ್, ಆಸ್ ಯು ಮೆನ್ಷನ್ಡ್, ಹೈ ರಿಸ್ಕ್ ಪೇಷಂಟ್ಸ್. ಅಂದ್ರೆ ಲೈಕ್ ಮೆಲಿಗ್ನೆನ್ಸಿ, ಡಯಾಲಿಸಿಸ್ ಪೇಷಂಟ್ಸ್, ಮೆಲಿಗ್ನೆನ್ಸಿ ಪೇಷಂಟ್ಸ್. ಅವ್ರ ಹತ್ರ ಆ ಡಾಕ್ಟರ್ಗೆ ಹೋಗ್ಬಿಟ್ಟು TBಗೆ ಹೆಂಗ್ ಡಿಟೆಕ್ಟ್ ಮಾಡಬೇಕು, ಇದಕ್ಕೆ ಏನ್ ಇನ್ಸ್ಟ್ರೂಮೆಂಟ್ಸ್ ಬಂದಿದೆ, ವೆನ್ ಯು ಡೋಂಟ್ ಗೆಟ್ ಡೆಫಿನಿಟಿವ್ ಡಯಾಗ್ನೋಸಿಸ್, ವಾಟ್ ಆರ್ ದ ಅದರ್ ಟೆಸ್ಟ್, ಬ್ಲಡ್ ಟೆಸ್ಟ್ ಯಾರು ಹೈಲೈಟ್ ಮಾಡಿದ್ದಾರೆ ಇವ್ರಿಗೆ?
ಸರ್ ನಮ್ಮಲ್ಲಿ ನಮ್ ಬೆಂಗಳೂರಲ್ಲಿ ಇದೆ ಸರ್. ಬೆಂಗಳೂರಲ್ಲಿ
ನನ್ನ ಫ್ರೆಂಡ್ಸ್ ಇದೆಲ್ಲ. ವಿ ಹ್ಯಾಡ್ ಎ ಪಲ್ಮೋಕಾರ್ನ್ ಸ್ಟೇಟ್ ಕಾನ್ಫರೆನ್ಸ್ ರೀಸೆಂಟ್ಲಿ. ಆಲ್ ಡಿಸ್ಕಷನ್ಸ್ ವೇರ್ ರೇಸ್ಡ್.
ಯಾಕೆಂದ್ರೆ ನಮ್ಮಲ್ಲಿ ಈಗ ಐ ಹ್ಯಾಡ್ recently looked at the utilization of CBNAT cartridges in private sector. Everyone 3000 CBNAT cartridges ಅದು ಅಲ್ಟ್ರಾ ಯೂಸ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ ಸರ್. ದೆನ್ ಸ್ಪರ್ಶಲ್ ಯೂಸ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ, ಅಪೋಲೋ ಯೂಸ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ, HCG ಅಲ್ಲಿ ಇದ್ದಾರೆ.
ಅದನ್ನು ಬಂತು. ಸಿನ್ಸ್ ಯು ಆರ್ ಗಿವಿಂಗ್ ಇಟ್ ಫಾರ್ ಫ್ರೀ, ಇಟ್ ಇಸ್ ಬಿನ್ ಓವರ್ ಯೂಸ್ಡ್. ಯಾರಿಗ್ ಬೇಕು ಯಾರಿಗ್ ಬೇಡ ಅನ್ನೋದು ಡಿಸೈಡ್ ಮಾಡೋದಿಲ್ಲ ಅಲ್ಲಿ. ಸಮಥಿಂಗ್ ಓವರ್ ಇದನ್ನು ಆಗಿದೆ.
ಇದೇ ಕಾರಣಕ್ಕಾಗಿನೇ ಸರ್, ಸಾರಿ ಫಾರ್ ಇಂಟರಪ್ಷನ್ ಸರ್, ಸ್ವಲ್ಪ ಗ್ಯಾಪ್ ಇದ್ದೇ ಇರುತ್ತೆ. ಇಟ್ ಈಸ್ ದಿ ರೆಸ್ಪಾನ್ಸಿಬಿಲಿಟಿ ಆಫ್ ದಿ ಪ್ರೈವೇಟ್ ಪ್ರಾಕ್ಟಿಷನರ್ಸ್ ಆಲ್ಸೋ ಶುಡ್ ನೋ ವಾಟ್ ಇಸ್ ಹ್ಯಾಪನಿಂಗ್.
ಅಲ್ಲ ಹೌದು, ಬಟ್ ಇದನ್ನ ನೀವು ಹೈಲೈಟ್ ರಿಪೀಟೆಡ್ ಆಗಿ ಮಾಡಿದ್ರೆ ಏನಾಗುತ್ತೆ, ದೇ ಕಮ್ ಟು ನೋ. ಅಂದ್ರೆ ಅದು ಗ್ಯಾಪ್ ಜಾಸ್ತಿ ಆದ್ರೆ ಅವ್ರ ಪಾಡಿಗೆ ಅವರು, ನಿಮ್ ಪಾಡಿಗೆ ನೀವು, ಹಂಗೆ ಹೇಳ್ಬಿಡ್ತೀರಿ.
ಇಲ್ಲ, ಕೆಲವು ಊರುಗಳಲ್ಲಿ ಆಗುತ್ತೆ ಸರ್. ನಮ್ಮಲ್ಲಿ ಎಕ್ಸ್ಟ್ರೀಮ್ಲಿ ಗುಡ್. ಎವ್ರಿ 10 days 15 days ಏನೇನ್ ಆಗ್ತಿದೆ ಅಂತ ಅವರು ಅಫಿಷಿಯಲ್ಸ್ ಪಾಪ ಗ್ರೌಂಡ್ ಲೆವೆಲ್ ವರ್ಕರ್ಸ್ ಬಂದು ನಮ್ಗೆಲ್ಲ ಮಾಹಿತಿ ಕೊಡ್ತಾರೆ.
ನಾನು ಹೇಳ್ದಲ್ರಿ, ನಾನೇ ಪಲ್ಮನಾಲಜಿಸ್ಟ್ ದಾವಣಗೆರೆಯಲ್ಲಿ. ಐ ಆಮ್ ಎ ಪ್ರೊಫೆಸರ್. ಐ ಹ್ಯಾವ್ ನೆವರ್ ಮೆಟ್ DTO ಆಫ್ ದಾವಣಗೆರೆ ಸಿನ್ಸ್ 5 years. ನನಗೇನು ನಡೀತಿದೆ ಅಂತ ನನಗೇನು ಹೈಲೈಟ್ ಮಾಡಿಲ್ಲ. ಡೈರೆಕ್ಟ್ಲಿ ಕಾಲ್ ಹಿಮ್ ಅಂಡ್ ಟಾಕ್ ಟು ಹಿಮ್. ನನಗೇನು ಹೈಲೈಟ್ ಮಾಡಿಲ್ಲಪ್ಪ. ಸೊ ಅಂದ್ರೆ ನಾನು ಹೇಳ್ತಿರೋದು, ನನಗೇ ಮಾಡಿಲ್ಲ. ಹೈಯೆಸ್ಟ್ ರೆಫರಿಂಗ್ ಡಾಕ್ಟರ್ಗೆ ಹೂ ರೆಫರ್ಸ್ ಟು ದಿ ಹೈಯರ್ ಸ್ಪುಟಮ್ ಪಾಸಿಟಿವ್ ಕೇಸಸ್ ನಮಗೆ ಮಾಡಿದ್ರೆ, ವಾಟ್ ಅಬೌಟ್ ದಿ ಸರ್ಜನ್ಸ್ ಅಂಡ್ ದಿ MBBS ಡಾಕ್ಟರ್ಸ್ ಪ್ರಾಕ್ಟೀಸಿಂಗ್ and other BMS, anybody. ಅವ್ರದ್ದು ಕತೆ ಏನ್ ಹೇಳಿ ನೀವೇ ಹೇಳ್ರಿ. ಅಂದ್ರೆ ಫಸ್ಟ್ ಹೋಗೋದೇ ಪೇಷಂಟ್ ಅಲ್ಲಿ, ಆಮೇಲೆ ನಮ್ಮ ಹತ್ರ ಬರೋದು. ಅಂದ್ರೆ ನಾನ್ ಏನ್ ಹೇಳ್ತೀನಿ, ಎವ್ರಿಬಡಿ ಶುಡ್ ಗೆಟ್ ಇನ್ವಾಲ್ವ್ ಟು ಎರಾಡಿಕೇಟ್ ದಿಸ್ ಪರ್ಟಿಕ್ಯುಲರ್ ಡಿಸೀಸ್ ಅಂತ. ಸೊ ಅದಕ್ಕೆ ನಾವು ಗವರ್ನಮೆಂಟ್ ಇಷ್ಟೊಂದು ದುಡ್ಡು ಖರ್ಚು ಮಾಡ್ತಾ ಇದ್ದೇನೆ, ಅದನ್ನ ಪ್ರಾಪರ್ ಯೂಸೇಜ್ ಮಾಡ್ತಾ ಇದ್ರೆ, ಬಟ್ ಎಲ್ಲೋ ಸ್ವಲ್ಪ ಗ್ಯಾಪ್ ಇದೆ. ಆ ಗ್ಯಾಪ್ ನ ಒಂದ್ ಸ್ವಲ್ಪ ಕಡಿಮೆ ಮಾಡಿದ್ರೆ ವಿ ಮೇ ರೀಚ್ ದ ಟಾರ್ಗೆಟ್ ಸ್ವಲ್ಪ ಮುಂಚೆ.
Yes, sir. I agree with you, sir.
ಆಮೇಲೆ ಇನ್ನೊಂದಿದೆ ನಮ್ಮ ಡಾಕ್ಟರ್ಸ್ಗಳಲ್ಲಿ, ಇದರಲ್ಲಿ ಮುಂಚೆ ಇನ್ಸೆಂಟಿವ್ಸ್ ಅಂತ ಕೊಡ್ತಾ ಇದ್ರು.
ಹಾ ಸರ್, 500 rupees ಕೊಡ್ತಾ ಇದ್ವಿ.
ಈಗ ಅದು ಇಲ್ಲ.
ಈಗ ಸರ್ ಅದು ಏನಾಗಿದೆ,
ಅದನ್ನು
ನಮ್ದು
ನಮ್ಮ ಡಾಕ್ಟರ್ಗಳು ನಿಮಗೆ ಹೇಳ್ತಾರೆ, ನೋಡಿ ಸರ್ ಈಗ ಅವ್ರು ಕೊಡ್ತಾ ಇಲ್ಲ, ಮುಂಚೆ ಕೊಡ್ತಾ ಇದ್ರು, ಈಗ ಕೊಡ್ತಾ ಇಲ್ಲ.
ಗೊತ್ತಾಯ್ತು ಸರ್. ಅದು
ಸೊ ಅದಕ್ಕೆ ನಾವೇ ಪ್ರೈವೇಟ್ ತಗೊಂಡ್ಬಿಡ್ತೀವಿ. ಅದು ಪ್ರೈವೇಟೈಸೇಷನ್ ಅದೇನಾಗುತ್ತೆ, ಫಾಲೋ ಅಪ್ ಇರಲ್ಲ ಪೇಷಂಟ್ಗೆ.
ನಮ್ದು ಏನಾಯ್ತು ಅಂದ್ರೆ ಎಲ್ಲರೂ ಈಗ ಮೊದ್ಲೇನಾಗಿತ್ತು, ಅದೊಂದು PFMS ಅಂತ ಇತ್ತು, ಅದು ತುಂಬಾ ಸುಲಭ ಇತ್ತು. ಈಗ ಪ್ರತಿಯೊಂದು ಆಧಾರ್ ಬೇಸ್ಡ್ ಪೇಮೆಂಟ್ ಮಾಡಿದ್ದಾರೆ. ಪೇಷಂಟ್ ಆಧಾರ್, ಡಾಕ್ಟರ್ ಆಧಾರ್ ತಗೊಂಡು ಕೊಡ್ಬೇಕು. ಈಗ ನೆಕ್ಸ್ಟ್ ಪೇಷಂಟ್ ಫೇಸ್ ಅಥೆಂಟಿಕೇಶನ್ ಮಾಡಿ ಅಂತ ಹೇಳ್ತಾ ಇದಾರೆ. ಐ ಡೋಂಟ್ ನೋ ಎಲ್ಲಿಗೆ ಹೋಗಿ ನಿಲ್ಲುತ್ತೆ ಅಂತ. ದೀಸ್ ಆರ್ ಆಲ್ ಪಾಲಿಸಿ ಡಿಸಿಷನ್ಸ್.
ಅಂದ್ರೆ ನಾನು ಮಲ್ಟಿಪಲ್ 1 by 1 ಹೇಳ್ಕೊಳ್ಬಿಡ್ತದೆ ಎಲ್ಲಿ ಗ್ಯಾಪ್ ಇದೆ ಅಂತ ಹೇಳಿ.
ಹೌದು ಹೌದು.
ಸೊ ದೀಸ್ ಆರ್ ದಿ ಗ್ಯಾಪ್ಸ್ ಸಿನ್ಸ್
ಹೌದು.
ನಮ್ಮ ಥ್ರೂ IMA, ಥ್ರೂ ಡಾಕ್ಟರ್ ವೀರಭದ್ರಯ್ಯ, ಥ್ರೂ ಡಾಕ್ಟರ್ ಸೂರ್ಯರಾಜು, ಸೆಕ್ರೆಟರಿ ಅಂಡ್ ಪ್ರೆಸಿಡೆಂಟ್, ನಾನು ಸೆಕ್ರೆಟರಿ ಆಫ್ ದಾವಣಗೆರೆ. ಐ ವಾಂಟ್ ಟು ಕನ್ವೆ ಥಿಂಗ್ಸ್ ಟು ದಿಸ್, ಇದು ಅಂದ್ರೆ ದೋಸ್ ಹೂ ಹ್ಯಾವ್ enrolled in the state tuberculosis programs. I think kindly consider these things, issues, and ಅದನ್ನ ಸ್ಪ್ರೆಡ್ ಮಾಡ್ಬೇಕು. ವಾಟ್ ಎವರ್ ಯು ಆರ್ ಗೆಟಿಂಗ್
We'll
ದ
do it,
ನ್ಯೂಸ್.
sir. Actually, Veerbhadraya had informed me, ಸರ್ ಮಾಡೋಣ ಅಂತ. ಸ್ವಲ್ಪ ನಾವು ಈ ಸೈಡ್ ಸ್ವಲ್ಪ ಬಿಸಿ ಆದೆ. ವಿ ವರ್ ಜಸ್ಟ್ 2 people in the state working. ಸೊ HIV-ನೂ ಇತ್ತು, TB-ನೂ ಇತ್ತು. ಅದನ್ನು ಮಿಷನ್ ಏಡ್ ಸುರಕ್ಷಾ ಅಂತಾನು ಮಾಡ್ತಾ ಇದ್ರು. We will definitely do it, sir. We are there.
Okay.
Sir, ಇದಕ್ಕೆ ಒಂದು solution we found in Tumkur, sir. So all over Tumkur there were 1,500 more than 1,000 doctors were there practicing. So ನಮ್ಮಲ್ಲಿ ಒಂದು TB HVs ಅಂತ ಇದಾರೆ sir staff. So we created each TB HV WhatsApp group of doctors. 100-150 doctor each TBHV. So through that DTO also will be there. So every week we used to convey another recent advance idre we used to give it in a. So Tumkuralli it was amazing, sir. 100% referrals.
Definitely, good
from
development. I think we
Yes,
should
sir.
the state TB program stakeholders should consider these issues and convey it to the district TB officers. ಈ ತರ ಏನೋ ಮಾಡ್ಲಿಕ್ಕೆ.
Yes, sir. We'll do it.
ಇಲ್ಲ ನಮ್ಮಲ್ಲೇನು ಸರ್ ಬಳ್ಳಾರಿಲಿ ವಿ ಹ್ಯಾವ್ ವಾಟ್ಸ್ಆಪ್ ಗ್ರೂಪ್ ಆಫ್ ದಿ ಡಿಸ್ಟ್ರಿಕ್ಟ್. ಅಲ್ಲಿ ಪಲ್ಮನಾಲಜಿಸ್ಟ್ಗಳು, DTO ಪ್ಲಸ್ ಫಿಸಿಷಿಯನ್ಸ್ ಎಲ್ಲರೂ ಆ ಪ್ಲಾಟ್ಫಾರ್ಮ್ ಅಲ್ಲಿ ಎಕ್ಸ್ರೇಗಳನ್ನ ಶೇರ್ ಮಾಡ್ತೀವಿ, ಕೇಸ್ ಡಿಸ್ಕಸ್ ಮಾಡ್ತೀವಿ. ನಮ್ಗೆ ಏನಾದ್ರು ಡೌಟ್ಸ್ ಬಂದ್ರೆ ವಿ ವಿಲ್ ಶೇರ್ ದ ಎಕ್ಸ್ರೇಸ್, ವಿ ವಿಲ್ ಶೇರ್ ದ ರಿಪೋರ್ಟ್ಸ್. ಡೆಫಿನೆಟ್ಲಿ ಪೀಪಲ್ ಆರ್ ದೇರ್ ಟು ಗೈಡ್. ಐ ಥಿಂಕ್ somebody should take voluntarily to get into this.
Sir, incentives ಇಲ್ದಲೆ nobody will come. Only the government should come forward for these issues. ಅವಾಗ ಏನಾಗುತ್ತೆ, those who are interested like me, ನಮ್ಮಂತರು, we can give advice ಫ್ರೀ. ಇದ್ರಲ್ಲಿ ಕೆಲವೊಬ್ರು ನಾನು ನೋಡ್ತೀನಿ ಸರ್, ನಿಮಗೆ ಇನ್ಸೆಂಟಿವ್ಸ್ ನಾ ಕೇಳ್ತೀನಿ, ಯಾಕಪ್ಪ ಕಳ್ಸಲ್ಲ ನೀವು ಅಂದ್ರೆ ಡಾಕ್ಟರ್ಸ್, ಮುಂಚೆ ಇನ್ಸೆಂಟಿವ್ಸ್ ಕೊಡ್ತಿರ್ತಾರೆ, ಏನ್ ಕೊಡಲ್ಲ, ನಾನೇ ಕಳ್ಸಿ ಸರ್ ಅಲ್ಲಿ ಅಂತಾರೆ. ದಿಸ್ ಇಸ್ ದ ಲ್ಯಾಂಗ್ವೇಜ್ ಯೂಸ್ಡ್.
ಇಲ್ಲಿ ಸರ್ ಆ ಇನ್ಸೆಂಟಿವ್ಸ್ ನಮ್ಮ ದೇಶನ ನಾವು ಇದ್ ಮಾಡಕ್ ಹೋಗ್ಬಾರ್ದು. ಸೋಶಿಯಲ್ ಮೆನೇಜ್ ಡಿಸೀಸ್. ನಾವು ಬರೀ ಇನ್ಸೆಂಟಿವ್ಸ್ ಗೆ ಕೆಲಸ ಮಾಡಕ್ ಆಗಲ್ಲ ಸರ್.
ಸರ್ ಕೇಳಿ, ಸರ್ ಪ್ರಾಕ್ಟಿಕಲಿ ಕೇಳಿ. ನಾವು ಸಿಕ್ಕಿ ದಾವಣಗೆರೆ ಬಗ್ಗೆ ಕೇಳಿ ಬೇಕಾದ್ರೆ ನೀವು. ಸೊ ದಿಸ್ ಇಸ್ ದಿ ಇಶ್ಯೂಸ್. ನೀವು ಪಲ್ಮನಾಲಜಿಸ್ಟಾ?
ನಾನು ಜನರಲ್ ಸರ್ಜನ್ ಸರ್.
ಸರ್ ನಾನು ಪಲ್ಮನಾಲಜಿಸ್ಟ್, ನಾನು ಜಾಸ್ತಿ ಕೇಸ್ ನೋಡ್ತೀನಿ. ನಾನು ಏನ್ ಹೇಳ್ತೀನಿ ಕೇಳಿ. ಈಗ ಸರ್ಜನ್ಸ್ ರೆಫರ್ ಮಾಡ್ತಾರೆ. ಯಾಕೆ ಈಗ ಅವರು ಮುಂಚೆ ಮಾಡ್ತಾ ಇದ್ರು, ಅವರಿಗೆ ರೆಸ್ಪಾಂಡ್ ಮಾಡೋರು ಹೆಲ್ತ್ ವರ್ಕರ್ಸ್. ಈಗ ರೆಸ್ಪಾಂಡ್ ಮಾಡ್ತಿಲ್ಲ, ಅವರೇ ಸರ್ ನಾನೇ ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡ್ತೀನಿ ಬಿಡ್ರಿ ಸರ್ ಅಂತಾರೆ. ನಾವು ಸ್ಟಿಲ್ ಇನ್ಸಿಸ್ಟ್ ಗವರ್ಮೆಂಟ್ ಕಳ್ಸಿ.
ಹಲೋ
ಆಮೇಲೆ
ಜಸ್ಪಾಲ್.
ತುಮಕೂರ್ದು
Yes,
ಬಳ್ಳಾರಿದು
sir.
ಐ ರಿಯಲಿ ಅಪ್ರಿಶಿಯೇಟ್ ಆ ತರ ಇರ್ಬೇಕು.
Madhu sir,
ಹಾ
my video I can't start. Okay. Yeah. Sir, after hearing all the questions and answers, now I think our students are waiting. Should we go ahead with our next protocol of continuing?
Yeah, you can conclude.
Yeah, conclude. Srinidhi, start with vote of thanks.
Yes, sir.
Can I leave?
Yep.
Sir.
Sir, 2 minutes, sir. We are
Okay.
completing. Yes, 2 minutes, just 2 minutes. Yes, sir.
Thank you, Anil. Thank you very much.
Thank you,
At this
sir.
time
Thank
you
you,
joined us.
everyone. Sorry,
Thank you.
I was
Nano.
telling that you are the
Okay.
authority for TB. You have answered
Thank
many
you.
questions. Thank you very much.
Thank you, sir. Thank you.
Sir, personally, thank you, sir.
Dr.
All the
Anil
best for your
Dr. Rajesh.
hospital ಗೆ.
Yeah,
Thank you very
thank
much,
you.
sir.
Thank you.
ಸಾರಿ, ತುಂಬಾ ಹಿಂದೆ ಬಿದ್ದಿದ್ದೆ ತುಂಬಾ ಸರಿ ಡಿಸ್ಟರ್ಬ್ ಮಾಡಿದೆ ನಿಮ್ಗೆ.
ಇಲ್ಲ ಸರ್, ನಾನ್ ಸಾರಿ ಕೇಳ್ಬೇಕು, ನನ್ನ ಸನತ್ಗೆ ಥ್ಯಾಂಕ್ಸ್ ಹೇಳ್ಬೇಕು.
ಎಸ್ ಸರ್, ಎಸ್ ಸರ್.
ಥ್ಯಾಂಕ್ ಯು. ಥ್ಯಾಂಕ್ ಯು.
Thank you very much, sir.
Yes, sir. And I would also like to thank on behalf of the MSN team, sir, if I may.
Thank you, sir, on behalf of IMA Karnataka State Branch. Thank you very much, sir.
Thank you, everyone. Thank you.
Thank you. Thank you.
ಸೂರ್ಯರಾಜ್ ಸರ್.
Thank you.
Thank you,
Surya,
sir.
sir.
Thank you. Sir, ಹೇಳಿ sir.
ಸರ್, ಒಂದು ಪ್ಲಾನ್ ಆಫ್ ಆಕ್ಷನ್ ಹಾಕೊಳ್ಳೋಣ ಸರ್ 1 year ಗೆ ನಮ್ಮ IMA ಇಂದ.
Okay, sir.
ಆಯ್ತು. ನಮ್ ರಾಜೇಶ್ ಅವ್ರಿಗೆ ಸೇರಿಸ್ಕೊಳ್ಳಿ ಅದಕ್ಕೆ.
Sir,
Sir,
He's very
ಹೇಳಿ
active. ರಾಜೇಶ್
ಯಾರು ಸರ್?
ದಾವಣಗೆರೆ.
ಹಾ, ಸೇರ್ಸ್ಕೊಳ್ಳೋಣ ಸರ್.
ಸೆಕ್ರೆಟರಿ ಸರ್. He's very
ಇಲ್ಲ,
active.
ಸೇರ್ಸ್ಕೊಳ್ಳೋಣ ಸರ್. ಸರ್, TB
ಅವ್ರನ್ನ
ಎಲಿಮಿನೇಷನ್
team ಗೆ
ಯಾರು
ಹಾಕೊಳ್ಳಿ.
ಬರ್ತಾರೆ ಎಲ್ಲರೂ ಬರ್ಲಿ ಸರ್. It
Sir,
is our
ಅವ್ರು
duty.
ಇದ್ರೆ ಒಳ್ಳೇದು.
Definitely. I am Dr. Rajesh. I would like to join to eradicate.
Yes, sir.
Done some ಸಣ್ಣ contribution.
Please,
I would
Rajesh.
be happy. Definitely,
Yes,
sir.
sir.
Thank you,
Yes, sir.
Rajesh.
Yes, sir. Yes, sir.
Thank you. Thank
Okay,
you.
sir. Bye.
I
ಎಲ್ಲರೂ
need support from Dr.
Next.
Sanath also because guidance and how to go ahead ಅಂತ.
Yes, sir.
His life
ಆಗ್ಲಿ
is
sir.
for TB.
Okay, sir.
Yes, sir. We'll
ಅದಕ್ಕೆ ಮಡಿಕೇರಿಗೆ ಹೋಗೋಣ ಅವನು ತುಮಕೂರು ಬಿಟ್ಟು.
End TB. Let us end.
No, sir.
Yes,
End TB.
maybe
Let
before 28 we'll end TB in Kodagu.
I think IMA KSP will play a key role in eradicating the tuberculosis, sir. Teamwork.
Yes, sir.
Work,
Good,
We
sir.
have to
Thank you.
we have to mantle this responsibility, sir.
Done, sir.
It is an opportunity. We have to take it as an
Yeah.
opportunity.
Yes, sir. Let us
Yes, sir. Thank you.
guidelines, sir. Guidelines pass ಮಾಡಿ ಯಾವ ತರ ಮುಂದಕ್ಕೆ ಹೋಗೋಣ ಅಂತ.
ಅಲ್ಲ, ಅದೇ 1 yearದು ಒಂದು ಅಟ್ಲೀಸ್ಟ್ ತಿಂಗಳಿಗೆ ಒಂದ್ಸರಿ ಒಂದೊಂದು DTO ಒಬ್ಬೊಬ್ರು ಇವ್ರ ಜೊತೆಗೆ ಸೋ ಮಚ್ ಆಫ್ ರಿಸೋರ್ಸ್ ಪರ್ಸನ್ಸ್ ಆರ್ ದೇರ್
Yes, sir.
ಇನ್ ಗವರ್ಮೆಂಟ್ ಸರ್.
Yes.
ಈಗ MDR TB ಬಗ್ಗೆ ನಮ್ಮ ಯಾವ ಫಿಸಿಷಿಯನ್ ಕೇಳಿದ್ರು ಹೇಳಲ್ಲ ಸರ್.
ಹೌದು.
ಆಮೇಲೆ ಟೆಸ್ಟ್ ಫಾರ್ ಟ್ಯೂಬರ್ಕ್ಯುಲೋಸಿಸ್ ಯು ಜಸ್ಟ್ ಆಸ್ಕ್ ಎನಿ ಫಿಸಿಷಿಯನ್,
Yes.
ಹಿ ವಿಲ್ ಬಿ ನೋಯಿಂಗ್ ವೇಗ್,
Yeah.
ಇನ್ ಡೀಟೇಲ್ಸ್ ಗೊತ್ತಿರಲ್ಲ ಸರ್.
ಸರ್, ಈಗ ನಾವು ಹಾಸ್ಪಿಟಲ್ಸ್ಗೆಲ್ಲ ವಿ ಮೇಡ್ ಎ ಸ್ಟೆಪ್ಸ್ ಅಂತ ಒಂದು ಇಂಟ್ರೊಡ್ಯೂಸ್ ಮಾಡಿದ್ವಿ ಸರ್. So in Kodagu district, all the hospitals been come up that. So steps ಅಂದ್ರೆ we give all the consumables, all the materials to the hospital so that presumptive TB ನ ಟೆಸ್ಟ್ ಮಾಡ್ತಾರೆ. So positive ಬಂದ್ರೆ we give the drugs there also. ಅಲ್ಲೇ ಇರ್ತಾರೆ drugs. They immediately start for completion, after completion of the treatment. So private doctor will get 2,000 rupees honorariums. So hospital will get. So each patient they have to follow up for 6 months.
Can we create guidelines for the each and every private hospitals in Karnataka, sir, from IMA Karnataka State Branch? This is the guidelines for tuberculosis identification.
We'll make and we'll distribute through this platform, sir.
Okay, sir.
So whatever the schemes available in government for the private sector,
Yes.
so definitely we'll make a guidelines and we'll distribute.
Okay, sir.
Excuse me, sir. I'm Shreya. On behalf of the MSN Karnataka State team, I would like to thank Dr. Gurram Krishnamurthy Sanat Kumar, sir, for the wonderful session. And I would like to take a moment to thank Dr. Anil sir as well for taking out time despite the family emergency. We truly appreciate that sir joined us and addressed all the questions so sincerely, even in such a situation. Thank you so much, sir.
Thank you all.
Thank you all, sir.
ರಾತ್ರಿ
Thank you, Sanath. Thank you all.